Good afternoon. I'd like to ask the captioner to send a test, please. If you're online, dynamic captioning, please send a test. Dynamic captioning, if you're online, please send a test caption. Dynamic, if you could please send a test. That came through. Thanks very much.
Good afternoon, ladies and gentlemen. This is the Santa Clara County Health and Hospital Committee, and the hour of 2 o'clock having arrived, it is time for us to begin the business of the afternoon. First item of business is simply this call to order, which requires us to ask the clerk to call the roll and establish the presence of a quorum.
Vice Chairperson Lee.
Good afternoon, President.
Chairperson Samidian.
Present.
Thank you.
We have a quorum. Thank you very much. That takes us to item number 2, which is public comment, and I believe we have one card under public comment. I'm looking to the clerk, and do we have anybody online?
We have 2 more online for public comment.
All right, well, we allow up to 3 minutes, so we will ask Adam Cole, who has submitted a card, to please come forward. And why don't we say that...
We're up to 5 now.
That's great. If we have 5, forgive me, Mr. Cole and others, but I believe that means our public comment is...
It just went down again. Just to clarify for those online, we're talking about open public comment for items not on the agenda. That includes regular and consent calendar.
Thank you, Madam Clerk. Ms. Cole, thanks for your patience while we sort out how many folks we have and therefore how much time we allocate pursuant to board rules.
Back down to the original 2 for items not on the agenda.
All right, thank you very much. Then what we'll do is we'll say, Mr. Cole, come forward. You may use up to 3 minutes, and welcome to the committee. And folks who are listening online, if you would like to comment under public comment on non-agendized items that are properly within the jurisdiction of this committee, please raise your hands, and we're going to give a 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. We have still 2?
Holding, yes.
Then we will go with 3 minutes. And Mr. Cole, forgive me, I cut you off.
I was going to ask if consent calendar is acceptable to speak on right now.
Consent calendar will be coming up in just a moment. So if you'd like to
I'll wait
speak
for
on the
that then.
consent,
Thank you.
we do have some other folks on consent as well, so
Okay,
we'll call you at that time. Thank you. All right. Let me just make sure we have no one else here in the chambers who wanted to speak under public comment. But we do have some folks online, yes?
Correct.
All right, let's welcome them. How many do we have?
Holding it 2.
Holding it 2. Welcome. Go right ahead, and again, you have up to 3 minutes.
Our first speaker is Ken Horowitz.
Mr. Horowitz, welcome.
Please go ahead.
Good afternoon. This is Dr. Ken Horowitz from your Health Advisory Commission. And I'd like to bring up 4 items, sort of a follow-up on, as you may remember, I brought up about dental services for approximately 500,000 Medi-Cal recipients in the county. And so I wanted to just remind the supervisors. In particular, Supervisor Lee brought up 2 items. One was to look into the San Mateo Health Plan, which currently integrates dental benefits to their medical benefits for their members, unlike we do for our family health plan of Santa Clara County. And then he also, Supervisor Lee, asked about the employment of dental hygienists in the county system. And I think he asked one of the members of the staff whether we do employ dental hygienists. And then, of course, Supervisor Samidian brought up about the fluoridation status in the county, and I think he asked the Public Health Department to come back with an off-agenda report. So I would like these 3 items related to dental services, perhaps they can be put on a consent calendar, what the findings were in an off-agenda memo. These 3 items in particular were discussed last month by our Health Advisory Commission, and our commission voted unanimously to support these particular recommendations, among a few others. And then finally, the 4th item was a referral that went back to December 8th, 2022, in which the committee voted 2 to 0 for a referral to develop an integrative medical discovery process to include functional medicine of a pilot in the county's health system. And we've been trying, our commission has been trying to reach out to the staff at the county health system, and we have not heard back whether this particular pilot is being developed. So I appreciate your time, and hopefully in the next few meetings, we can get an off-agenda report as part of the consent calendar. Thank you.
Our next speaker is Ben Z. You'll have
Thank-
3 minutes.
Yes, hello, good afternoon. I wanted to point out to this committee that we are having an issue in our health system when it comes to screening children who report being sexually abused. And we're having this problem in Santa Clara County because sometimes we have conflicts of interest. For instance, in my case, my son, he reported that he'd been anally raped beginning from the age of 13, that my ex-wife was allowing this to occur. And the reason there's a conflict of interest is because my former attorney, she wants this sexual abuse to continue. And this just isn't happening just with my kids. This is happening with other parents in the county who I've been in contact with. It's abysmal what's going on in this county because we have mandated reporters and we have mandated actors, and the mandated actors, they're not doing their jobs. They're going with this conflict of interest, and even though my other children are also showing signs of the same sexual abuse, the county is refusing to conduct a screening. I mean, you have a child who reports being sexually abused, you go and you do a screening. There are no exceptions. I mean, and there should be no exceptions, but apparently in this county, we do have exceptions. So what I wanted to ask, if there is anybody on this committee or anybody present at this meeting, if you could help me get a screening for my kids, I greatly appreciate it. Is there somebody here who can help me? Supervisor Lee has all of my contact information. If you can help my kids, I mean, like, I don't know if there's anybody here who knows what it's like to be a parent and to be worried sick about your kids. I mean, if there's somebody who can empathize with that feeling that I want to help my kids, if there's somebody who can help me, please talk with Supervisor Lee. My name is Ben Z. He's got all my contact info. And thank you very much. Thank you for your time.
And
Madam Clerk?
Chairperson Sminian, we had one hand go up after the start of public comment. Would you like to take that speaker?
I think with the consent of my colleague, we'll go ahead and hear from that speaker. I will ask speakers today to please try and be timely in the raising of hands, because that's how we determine how much time is available. And of course, in this instance, we did do a countdown from 10 to let everybody have a chance. But so again, for those who are listening, please do try to be prompt in raising your hand so we can accommodate you. Going to be a little less flexible on that, I'm afraid, as the day goes on. But right now, let's go ahead and hear from the speaker. Go right ahead, speaker.
Thank you. This is Melanie Govind. We'll open your microphone. You'll have 3 minutes to speak. Please go ahead. Melanie, we see your microphone on. Can you go ahead and speak?
Hi, I'm trying to speak on the agenda consent calendar. So I don't know if I need to wait or if I could go ahead right now.
If we can ask you to wait, we will put you at the beginning of the queue for the consent calendar when we get there. How's that?
Okay.
We'll try.
Sounds good. Sounds
All right.
good. Thank you.
Thank you. All right. That takes care of public comment for the moment. And I'm going to ask Ms. Christian from my office to follow up on the request that we got from some of the earlier speakers, because we're not in a position to do that in real time here at the board meeting. Two other things I should indicate. When there are comments either in person or by Zoom that are difficult for any reason, sometimes they're explicit or graphic or painful, sometimes they are what many of us would deem to be wholly inappropriate. We have been advised by legal counsel that the best practice is to continue to hear those comments consistent with the guidance we've been given by the courts about folks' free speech rights and the Brown Act. So I share that with you all just so that if any of you are wondering why no member of the committee leans forward to intervene, the chair in particular, it's because that's our best understanding of the state of the law these days in terms of folks' right to access their government. Now, having said all of that, I should also indicate, as I did at an earlier meeting today, apologies, I have my cell phone turned on today uncharacteristically, and if the phone rings, I'll stand up and excuse myself briefly. So, not the norm. All right, we do have 1, 2, 3, 4, 5 folks who have submitted cards to speak under consent calendar, and we will get to those in just a moment. How many do we have online, Madam Clerk?
1 and rising. Again, if your intent is to speak on any item on the consent calendar, now's the time to raise your hand in Zoom.
All right.
Holding at 2.
All right. Supervisor Lee, would you like to move approval of the consent calendar so people
Yes,
know?
I actually like to go and move approve and also add item number 7, if it's amenable to you, to item number 7 is to receive report from the Santa Clara Valley Healthcare and Social Services Agency relating to Medi-Cal eligibility redetermination community outreach to the consent.
I'm happy to second that, and just so folks know what the consent calendar now contains, it will consist, if approved, of items 7, 13, 14, 15, 16, 17, 18, 19, 20. So items 7 and then 13 through 20. All right, Mr. Cole, this is your moment. And now we have 2 minutes. And you will be followed. And let's ask folks to just queue up if they can in the center so we can get you to the microphone expeditiously. I believe it is Enrique Alvarez. And then I believe it's Marie Maupassant. Am I close? And Kathleen Harrison and Laura Seidel. Welcome.
Welcome. Good morning, Board. Thank you for the opportunity to speak. This is Adam Cole with SEMA. In the coming weeks and months, you'll hear a more comprehensive response from SEMA on the proposed county budget, particularly on our health and hospital system. Overall, I would say SEMA understands that there's a budget deficit, positions need to be cut, and many of those positions are going to be SEMA positions, both filled and vacant. We're going to be identifying some small number of priorities from SEMA's perspective about positions that are going to have an outsized impact on the organization through cutting or may actually cost the county money. I'm here to identify one position for you today that's being proposed for cut. This is a filled position in our custody health. It is an administrative service manager 2. Around the county, our administrative service managers help drive change in their departments. They're the ones that help managers get positions filled, work with ESA, and take care of backside work that managers are too busy being nurse managers to deal with. The ASM2 is going to be a critical position as custody health looks to transition more budget dollars to frontline clinical care positions in line with what the monitor is requesting. If we saddle all of the work on filling those positions and working with our ESA and hiring teams to fill those positions on our already overtaxed managers in custody health, it's going to inhibit that change process. That ASM2, Administrative Service Manager 2 position in custody health, is a position that's critical for custody health. You'll hear more about this from SEMA and a couple other priorities in health and hospital in the coming weeks if we have more of a chance to look at this budget in overall context. I would end by saying I want to thank all of our executives here on health and hospital. I think reading through the budget was a tremendous amount of work to get to this point. I think in SEMA's perspective, these are some of your highest functioning executives we have here in the county. We were very pleased to see the budget overall. We'll be identifying some small number of priorities that are going to cause outsized damage. Thank you.
Thank you. And that takes us to our next speaker, who I believe is Enrique Alvarez.
Correct.
Welcome.
Thank you. Ready?
Ready.
Yeah, so I just want to talk about the behavioral health proposal to close with Glad Clinic Kids Scope. You have it in the consent calendar. I've been a social worker in direct service to the community, Spanish-speaking community, for 22 years. I've been working at Kids Scope for 9 years. In these 9 years, I developed a specialization in working with children with developmental challenges, learning challenges. So my caseload is very specific to that population, especially now with a lot of immigrant families coming. So we, in addition to mental health, we do a lot of support, a lot of case management support and advocacy for education. I understand that budgets change. I've been in the county 22 years. There's been many changes in the last 22 years, many budget challenges. And we had always worked with the county staff in addressing that. The Behavioral Health Department proposal indicates that there's going to be no impact on the community. And that is the most difficult thing to hear, that after 9 years of service in a clinic, that my work is not going to be missed, that they're claiming that there's going to be no impact on the community. So I urge you to find more information about it. I urge you to ask more questions. They claim that there's going to be 26 providers that are going to take care of this flow of referrals that we receive. So I urge you to ask questions, be more inquisitive of what do you mean that there's going to be no impact. You're closing a mental health clinic during a crisis in mental health. So thank you.
Thank you. And Mr. Alvarez, if I can ask you to look to the chambers where Danielle is waving at you, if you just give her your contact information. She's the health policy aide in my office, and I just want to make sure we have the opportunity to follow up. And our next speaker, and please help make sure I get this right, Marie Mauboussin.
Yeah, my name is Marie Lucille Mauboussin, and I'm a social service analyst at the
And I'm going
department.
to stop your time because I want to ask you to give me your name one more time, loud and clear, so I get it right.
All right, my legal name is Marie Lucille Mauboussin. I usually go by Marie Mauboussin.
Mauboussin.
Yes.
Got it. Thank you very much. Go right ahead.
And I'm a social service analyst at the Department of Social Services for the Transformation Team, which is our commercially sexually exploited children, those who are at risk, suspected, or confirmed. And we have a multidisciplinary team, so we work with probation, we work with public health, and we work with advocates, and we work all together to address the needs of these children. It's my understanding that we're going from 4 therapists at the Department of Health, Behavioral Health, down to 2, and that would be devastating. We've worked really hard to try to really get this program together and to, really, we get specialized training. They're continually new information. It's a lot of work, and it's a lot of consistency, and it's just like a lot of working together. And it's, not everybody can work with sex trafficking victims. And it's not like, I was told it was 26 other community-based providers could do the same level of care, and I strongly disagree with that, having worked with, this team and doing this for as long as I have. We have specialized training. We work together closely. We have the same understanding. We work, really to make sure that everything goes really well. Our therapists meet the clients in the community. That's all the way from Gilroy to Palo Alto. They have to go on a regular basis to go out to the youth. And sometimes the youth is willing to meet with them, sometimes they're not. They're very hard, they're difficult to work with because sometimes they're very available and sometimes they're hiding or they're not available. But it takes a great deal of time and energy to be able to work with them effectively, and we need staff who are willing to go out there, who are willing to have the energy, the willingness, and the education to really be able to work with them.
Thank you, Ms. Mauboussin. Our next speaker is Kathleen Harrison, who will be followed by Laura Seidel. Welcome.
Thank you. I am a psychiatric social worker too. I work in the transformation team clinic. I am the one that, one of the 3 right now clinicians that are providing services for our CSEC youth. It is suggested that the reduction to 2 clinicians would not have an impact on our clients, and I very much disagree with that. Like Marie said, we're a very specialized, highly trained group of clinicians that closely team with the other transformation partners, with probation, Department of Family and Children Services, and actually the rest of the community, public health nurse. We have our own psychiatrist. I just think that reducing to 2 clinicians is really not going to do our community justice. For example, 32 clients in 6 months cannot be managed by 2 clinicians. That's what was reported, that we've seen 32 clients in 6 months. With 2 clinicians, we wouldn't be able to meet that need. And since we see clients more for longer periods of time, I have 2 clients that I've seen for over 2 years. You know, we're providing a service that a lot of clinics can't provide because they require to close. We don't require to close. We see kids up until they're 24, and that provides a continuity of care that our clients really, really need. So, you know, right now, between 3 of us, we have, I think it's 25 clients. If one of us leaves, we'll each have 12 clients, and we will not have room to take any more referrals. So, thank you.
Thank you. And our final speaker here in chambers, Laura Seidel.
Good afternoon. My name is Laura Seidel. I'm a psychosocial occupational therapist at Kidscope. I've been there for 9 years. My role is to support the birth to 5 and the school age teams in working with our specialized population of children who have mental health challenges and are also experiencing developmental delays or have neurodevelopmental disorders such as autism. As you know, this is a very high-risk population, and at Kidscope we have a multidisciplinary team with decades of expertise and specialized training in supporting these children. Our 9 clinicians and OT, we speak 5 different languages. Our population is almost exclusively immigrant families, many Spanish-speaking, but also Mandarin, Tagalog, Vietnamese. We have those capacities within our clinic. We work very collaboratively with our pediatrics providers. They refer many young children to us as well as older children who have experienced challenges in school, mental health challenges for years, and oftentimes we're able to identify that something has been missed, link them to pediatric care to identify a developmental disability that is extremely impacting their functioning and supporting their family. We also work with medical legal partnership to support educational advocacy. We link families to the comprehensive system of whether it's early intervention, special education, specialized resources. Our team has that knowledge and those skills and the ability to take the time with families to help them learn to navigate those systems. So while there are other providers that serve birth to 5 and serve school age, the skill set and the capacities that exist are not something that can be easily replicated. So while there may be 26 other providers, it will not be the same experience for families. And that is a very significant impact in a time when pediatric mental health is identified as a crisis.
Thank you very much. Let me just confirm with the clerk, we have no other speakers here in chambers on
That's
this
correct.
item.
That's correct.
All right, turning to folks on Zoom, how many do we have now?
We had 2 hands raised at the start of the item. At this very moment, a 3rd hand went up.
I'm sorry, what was that about a third hand?
Just this moment, a 3rd hand went up.
All right. I think we're going to cut it off at 3 and say thank you very much. Let's go ahead and hear from those 3 speakers, each of whom will have up to 2 minutes.
Our next speaker is Charla Keibel. You'll have 2 minutes. Please go ahead.
Good afternoon. I'm here in support of sustaining the specialty knowledge and institutional memory in the Kidscope team. I worked at Kidscope for many years and trained and supervised many of the clinicians, and I'm currently retired from the county, but it would be a huge loss of capacity, as Laura Seidel so beautifully described, to take away a concentrated source of expertise, which not only has supported other county clinics, but has supported the multiple providers in the community who have partnered with Kidscope to support the highly vulnerable populations, not only due to being immigrants, but due to the high number of families with neurodevelopmental differences, where early intervention and identification is crucial and can make a huge difference to the trajectory of these children's functioning. I'm a national and international trainer in multi-dimensional diagnosis for young children, and I can tell you that I have seen expertise across many settings, many regions in California, across the United States, and in other countries. And it is very difficult to build up a core of expertise and knowledge and skill and to get endorsed by professional organizations, of which Kidscope has a very high number of endorsed professionals. And it is a resource that would be very difficult to recreate, and to distribute these clinicians elsewhere would be a huge loss. I urge some thought about preserving it. Thank you.
Thank you. Our next speaker, please.
Melanie Govind, you'll have 2 minutes. Please go ahead.
Good afternoon. My name is Melanie Govin, and I'm a clinician on the Birth to 5 team at Kidscope. I would like to address the Behavioral Health Services Department budget proposal to consolidate Kidscope Behavioral Clinic. The proposal notes that other clinics in the vicinity can carry out the same care provided by Kidscope and that there is no service impact. However, closing Kidscope would result in a tremendous loss for our children and families that we serve, because at Kidscope, like Charla and Laura Seidel had mentioned earlier, Kidscope clinicians are seasoned, providing high quality care. The majority of clinicians on the Birth to 5 and school age team are licensed. We hold various certifications, and we've completed cutting edge evidence-based practice trainings. Our clinicians, like I said earlier, we provide languages in Spanish, Vietnamese, Mandarin, Cambodian, and Tagalog. Most of our clinicians worked alongside developmental specialists like behavioral pediatricians, psychologists, psychosocial occupational therapists, and a speech therapist. We work closely together, and it provided us clinicians a unique lens for assessing children who not only have mental health, but developmental concerns as well. In addition, we are 1 out of 3 county clinics that provide behavioral health services for uninsured youth. If Kidscope closes and an uninsured child needs behavioral health services, then they would be sent to the 2 other clinics, county clinics serving children, and they are a greater distance away. The quality of services at Kidscope is unparalleled to any other clinic within the county and contracted agencies. I sincerely request to think further about keeping Kidscope remaining in operation so that children can continue to receive the high quality services that they deserve. Thank you.
And I believe we have one more speaker, Madam Clerk.
Our final speaker is Ben Z.
Thank you.
Please go ahead.
Yeah, we definitely need to rethink, how we're doing our budget with the behavioral services. I mean, like there was a member of a clinician from the transformational team. She says she works with child sex trafficking, and you guys want to cut out clinicians that work on this team. And it just is indicative of how this county is callous towards child molestation. And I mean, like, you could see the callousness when there's a disclaimer at the end of my pleas for help for my kids. There's a disclaimer saying it's difficult or it's inappropriate to voice these things that are happening to my kids. I know they're not Supervisor Simidian's kids; they're my kids, and it's just a callousness. Like he should have said, you know, like, how can I help? I mean, he's got all the information already, but what he should have said was, how can I help? Contact my office. You're not getting a screening for your kids, and your son has already confirmed it, and your other kids are showing signs of it. Call my office, because I'm concerned about the community. I'm concerned about the kids. Because this is unacceptable that things like this are happening in Santa Clara County. And I wish I would have heard that, but I didn't hear that. I heard a disclaimer at the end. And we need to improve our attitudes about, I mean, we just had a child, baby Phoenix. He passed away because of negligence. And that's already been shown. It's already been proven that there was negligence from the county. And I'm seeing this negligence for my kids. You guys are just gaslighting me. The county is gaslighting me. All I'm asking for is a screening. And I hope that I get one, and I hope we don't cut other people who are doing this kind of work. Thank you very much.
That concludes public comment.
Thank you, Madam Clerk. For folks who participated either online or here in chambers, and whose remarks were directed to essentially item 15, dealing with budget proposals from the various departments reporting to and through our Health and Hospital Committee, I just want to provide an indication that the only action we take on consent today is to receive the report. So I'm going to look to County Counsel, who I think is nodding his head at the end. I'm going to look to our Chief Operating Officer, if I could see her through Supervisor Lee, there she is, and just ask you to confirm by the nodding of heads that the only action taken today is to receive the report. And your comments are well timed because this is the beginning, far from the end of the process in June. All good, County Counsel, is that accurate? I'll take a yes. And Ms. Hanson, as our Chief Operating Officer, yes? Got it. All right, good. Thank you very much. We have heard from members of the public. Can we get a motion? We have a motion, forgive me, on the floor to approve the consent calendar as contained in our published agenda with the addition of item number 7. I have seconded that motion. Please call the roll.
Vice Chairperson Lee.
Yes, with the caveat, as mentioned, that this yes vote does not mean we agree to the cuts. We're just receiving reports. Thank you.
Chairperson Simidian.
With my caveat previously mentioned, I'm an aye vote as well. Thank you very much.
Thank you.
All right, that takes us then to item number 4, which is to receive the report from the Public Health Officer relating to COVID-19. Let me begin by asking if we have any members of the public who have submitted cards or are online who would like to speak to this issue. Item number 4.
I have no requests to speak.
All right, then we'll go straight to the report.
Right. Thank you so much, Mr. Chair, Mr. Vice Chair. Pleasure to be here. Sarah Rudman with Public Health, and I have a very brief report for you today with primarily very good news. So I'm just going to focus on the wastewater of the 3 respiratory viruses that we track that really help us define our respiratory virus season and indicate that we are at some of the lowest levels of all of them that we've seen in some time. So first you see the COVID wastewater levels, where we're right on the cusp between the low and medium levels for all wastewater wastewater sheds in the county. Likewise, for RSV, we have seen sort of what looks like the winter virus season come and go with respect to RSV, and then reflected in all sewer sheds. And then finally, for influenza, we did see a bit of a later season in Gilroy than in other parts of the county, but that also seems to have passed. And so at this point, our data support what we've seen historically for flu and RSV, and what seems to be becoming increasingly the trend for COVID, that we are through our winter respiratory virus season. And so while we'll continue to track and publish these data and offer people an opportunity to know what's going on around them and understand how to gear up for next year's season, that will be our priority, is focusing on what's to come to keep people healthy, not just throughout the summer, but next winter. Thank you.
Thank you. Can we go back to the first slide, please? If I'm reading this correctly, the Gilroy sewer shed is the one that is low. Is that correct?
That's correct. They are just below the cutoff, and everyone else is just above the cutoff.
And I'm asking about this one because during the crunch of the COVID crisis, we were often concerned about the level of services available in the South County. So this is a little counterintuitive, at least for me. Any thoughts about why this might be low when other parts of the county are at a higher level? I inferred from what you just said that the difference is perhaps relatively modest.
Not only is the difference very modest, but I think just a few weeks ago, some of these were reversed and Palo Alto was in low and Gilroy was in medium. So overall, I don't consider this to be a significant difference between these areas. What I also would add is I think the variation we see and the overall trends driving, we now know are much more complex. It's not just as simple as is it winter or summer, or are there high vaccination rates or lower? It has to do with in sort of tiny neighborhoods, the overall trends, multiple disease spreads, such that you're going to see little variations, small spikes in one area that haven't met another, and then those patterns may reverse. So as the tools we have to fight COVID become sort of more utilized, more widely available, and the disease is hitting us less hard in terms of who ends up in the hospital, I expect we'll see some of these variations and not ultimately think that they have a great deal of impact on how we need to approach the particular areas.
All right, thank you. Supervisor Lee, any comments or questions?
Yes, actually. Have we heard anything new about potentially some new COVID-19 vaccine coming up this coming fall, or we're still basically looking at using the same ones that we have currently?
We do continue to hear, I think Supervisor Simidian once pointed out my using the word signaling, which is what I say when FDA is being fairly opaque and we can't figure out, they're hinting at things but not saying them outright. So they continue to refer to an expectation that there will be a new vaccine in the late summer or early fall, but without providing any specifics of, as yet, what strains will be included in them or the exact timing, rollout availability, or anything like cost considerations that ultimately I'll be looking forward to sharing with this body as soon as we know them.
Great. That's all I have. Thank you very much.
Thank you. We are only asked to receive the report. Can I get a motion to that effect? Motion by Lee, second by Simidian. Call the roll, please.
Vice Chairperson Lee?
Aye.
Chairperson Simidian?
Aye.
If I could please make a general request that everyone get closer to their microphone going forward. Thank you.
Will do.
Thanks very much.
Thank you. That item passes unanimously. That takes us to item number 5, which is for a broader report from the Public Health Department relating to the state of the county's health.
Thank you. And for this item, I'll mention that both the narrative in the legislative file and the slides are going to contain a lot more information that I'm actually going to preview verbally for you today. So this item really serves as a teaser of a broader report we anticipate to come in the coming months from the Public Health Department. And to make it clear to you as our leadership for the Health and Hospital Committee and to the broader community we serve, that there is a lot of detailed data science happening in the Public Health Department that ultimately drives all of our decision-making and activities. So what I've shared with you today here are first this framework, which comes from a group called BARHI, which is describing in nitty-gritty detail, if you have the full version of the slide, all of the ways we attempt to create healthy environments and ultimately overcome racial disparities in health outcomes in our community. And the goal of the Public Health Department is to work as far left on this visual as possible, starting with the environments people grow up in, the social inequities, the institutions, the living conditions, so that we keep people from needing as much of the intervention on the far right, direct health care or support through serious illness or injury. But some of the ways we do that are always grounded in data, and that's what ultimately, when this broader report is available, we'll talk about. And today I'll give you really 2 examples that I think perfectly illustrate how we look across the entire life course in public health, starting with birth and ending with death. So I will start by sharing, I think, one of the most important items we think about in public health, which is infant mortality and what we know about pregnancy, pregnancy conditions, survival of pregnant persons after delivery or throughout their pregnancy, and the health environment that starts immediately at birth. And I think one of the most striking conclusions when we look at these data are the incredible disparities that are shown by the nearly double infant death rate among African ancestry Santa Clara County residents compared to the county overall, or the next highest group, Latino residents. And so while there is a lot that could be discussed, digested here, and in fact, this past week has been one in which we've focused on Black maternal health and shared a lot of that information and insight about why this happens and what we do about it, I'll highlight just very briefly that in the Public Health Department, we have 2 programs specifically focusing on this issue. The Black Infant Health Program, which focuses on supporting individual pregnant people, parents, families, infants, as well as the Perinatal Equity Initiative that focuses at the policy and systems level. But we also have multiple other systems looking at all vulnerable pregnancies, parents, and infants and early childhood to help support them. And then to look at the complete other end of the life spectrum, we constantly ground our work in what are the leading causes of death in Santa Clara County, where do we see disparities by races, ethnicities, genders, zip codes, and what patterns do we see that help us guide ultimately where our work is going to be most powerful in allowing people to lead long, healthy lives in Santa Clara County. And so for many years, we've seen this general pattern in front of you where cancer is the leading cause of death in Santa Clara County, followed by heart disease, then unintentional injuries, which includes drug overdose death, and stroke, which has actually been, of these, the one that has risen most recently. And then COVID-19, you can imagine, prior to 2020 was not on this list at all, and then came in at number 1 initially, but has fallen now to our number 5 cause of death in 2022, our latest data. And so again, without going into detail about these programs that are entire teams with entire careers making massive impact, I'll just highlight, and the slides and narrative will tell you about just a few of the ways we tackle these particular causes we know are so ultimately detrimental to our county and their residents. So we have multiple programs designed to focus specifically on reducing cancer risk, doing so through tobacco reduction, nutrition improvement, and immunization. We have multiple programs that ultimately serve to reduce heart disease and stroke, often through focusing on diabetes, outdoor exercise and ability to do so safely, and again, nutrition programs. And then we have finally a particular focus, as we know, on accidental deaths and drug overdoses in deep collaboration with both my colleagues in behavioral health and SCVH. Really focusing on the significant, again, racial disparities we see when it comes to drug overdoses, which are often somewhat masked by the numbers of the population in Santa Clara County. Because we have much larger white and Latino populations overall, the total numbers of deaths often appear to be disproportionately white and Latino. But when we actually look compared to the population size, it becomes obvious, as in this visual, that unfortunately the highest risk of overdose death is borne by our African ancestry community members. And so all of these populations are served and surveyed and focused on when it comes to the Public Health Department's efforts to reduce overdose. But paying attention to those disparities drives much of what we do. And so in addition to other types of accidental deaths, like reducing traffic deaths, we also focus all of our overdose data to action work on those community groups that are being hardest hit. And then finally, I'll wrap up by sharing a bit about what we know about homicide death. While fortunately not being one of the top 5 killers in our county, shows the most dramatic racial disparity. And so again, I wanted to highlight that here, that when we look at homicide death, we see significantly higher rates among African ancestry community members, followed by Latino community members compared to all other races and ethnicities. And so again, public health has a wide range of activities focused on both directly serving the county and understanding how to prevent violence, as well as partnering with other county entities and non-county community groups families to do this work to try to reduce the amount of homicide, death, and life lost in our county. So that, again, scratches the very surface of the kinds of data public health uses to focus our priorities, to including in helping us understand how to face budget crises by knowing where we need to push hardest to sustain. But all of that, the information we are doing, we're constantly working to make public. And so we, in addition to frequently publishing population-specific health assessments, disease-specific health assessments, also have an open data portal where anyone in the county can go find specific types of data and make their own judgments and guide us in our work. So I'll be very happy to take any questions, and thank you for the opportunity to share a bit of what we're doing.
Thank you. Before we go to board members, forgive me, did we check in on whether or not there were speakers on this item?
We have not yet on 5. I have no requests on Zoom or in the room.
All right, no speakers on this item. Supervisor Lee, comments or questions?
Yeah, first of all, I just want to thank Dr. Redmond for a very comprehensive report. It certainly has indicated various disparities. The area of African Americans having the worst infant mortality rates by more than double. But that's not just one area, right? It's just so many different areas where you see the African Americans impact is just so much greater, from drug overdoses to other type of illnesses. I guess I'm perplexed about this. Is there anything really that we can do more specifically now that we have these data in front of us to address African Americans specifically in order to bring some relief or attacking this head on?
I think that's exactly the right question, and the answer could take me a couple of days. I think the first step is asking the question, why do we see this awful disparity? The first step is also feeling the outrage that I think it should inspire in us, and understanding that we'll need to turn that sadness and anger into action. Programs like the Black Infant Health Program and the Perinatal Equity Initiative are one tiny step in thinking about how do we find individual vulnerable families, or how do we find specific policy changes that might undo what is really the health impacts of centuries of systemic racism. And the more we learn about the science behind what I'm describing here, the more we understand that it is not race, it is racism that is the background that explains all of these disparities. But the work to undo it can happen in almost any of the activities happening anywhere in the county. And so that's why it's a much wider conversation. And just to touch on some examples, I think it's integrated into our violence prevention work when we seek out community members of African descent or Latino descent as well, to help instruct us on what our activities should look like, to help us make sure we are interpreting the data the right way, to help make sure we're asking the right questions, conducting the right studies, and to make sure that the resources we have are being put to the right use. I can also say that the programs like the Perinatal Equity Initiative, in coordination with some of our board champions recently, have also had a bunch of trainings for healthcare professionals to help them understand how institutional racism shows up in healthcare and how we can counteract that by the right kinds of trainings, and even by the right clinical protocols that change the way we address unique health needs of African ancestry mothers. So that is just the very tip of what came to mind for me. But I think it's important to know the work is happening, but also never happening enough. And there are probably other ways we're consistently looking to do more.
Right, and to see that these works in the future, obviously we need to monitor this data very closely. And these type of programs that you mentioned, one being the Black Infant Care, and is there any way we can even try to measure the improvements based on time? Hopefully that these things being implemented is making a dent and making a difference.
Right. I mean, I think that is a constant struggle in public health because we're often measuring ourselves against what if we didn't exist at all. There's so much else changing in the environment that things may be less awful than they would have been if we hadn't been doing a certain activity. And to that point, I think part of what's especially heartbreaking is nationally, these infant mortality rates are worse than they used to be. That's actually true across all racial groups, but especially true for African Americans, such that the racial disparity is even worse. And that is despite the Black Infant Health Program having been in existence for almost 30 years. However, the Perinatal Equity Initiative is really only a few years old and really just hitting the ground, looking at, instead of serving one family at a time, one pregnancy at a time, how can we make entire sweeping policy, educational resource changes that battle these issues? So this is something we attempt to measure both at this very big picture level and down to the what can we say about the families served compared to the families we don't have the resources to serve. We are measuring that, and I would be very happy to come back regularly and share how we're doing. But ultimately, this work happens in the face of centuries of structural racism and violence that we are counteracting. And so even a comprehensive program like these can't stand alone in combating that history.
Yeah, one thing that has been very eye-opening and sad is the fact that when it comes to Black maternity health impacts, it turns out that the wealth or education background actually has not much of a change. Frequently, people thought that, well, those who are poorer tend to have worse health outcomes. But when it comes to African American infants and mother, it turns out that it didn't really matter whether they have PhDs or they are very wealthy versus those who are poor. These type of disparity is so daunting and clear that I'm just dumbfounded to say that this basically, is there any other type of programs that we look at, besides what we have right here, any other program in other counties that have adopted to try to solve these issues in a more strategic or fashion so that we are truly aiming at this most vulnerable population? And I would love to find out maybe in the future for you to bring back to us, not today, understood, but do some research and see what else is being done elsewhere in other part of the country to see if there are any type of proposal we could look into adopting to really try to attack this head on.
Yeah, I'll add that some of the national experts in understanding Black maternal mortality and morbidity are working right here in Santa Clara County, and we've been very honored to partner with them and bring them into our Perinatal Equity Initiative workshop that we did last week and some key events even just yesterday. So a lot of the innovation is happening here and then needs to happen at a national level. And exactly as you're describing, based on that very large, very rigorously done California study looking at maternal mortality and morbidity and infant mortality and morbidity, did demonstrate that this disparity runs so deep that it is not overwhelmed or explained by wealth, education, or access to other resources. So I'd be very happy to look into programs emerging elsewhere that we're not doing. But I think much of where we're focused right now are at some of the root causes of racism and disparity and how we can attack those, as well as some of the work emerging at the federal and state level to improve health care for African ancestry birthing people and making sure they're getting the absolute best modern care that has been demonstrated to keep them healthy and safe through pregnancy and delivery.
Good. Okay, thank you very much.
Thank you.
Thank you. I have no additional comments or questions. Confirming once again, we did not have speakers on this topic.
That's correct.
All right, then a motion to receive the report, Supervisor Lee?
So moved.
Seconded by me, Supervisor Simitian on the record, and let's call the roll.
Vice Chairperson Lee.
Aye.
Chairperson Smidian.
Aye. Motion carries unanimously. Thank you very much. That takes us to item number 6, suicide prevention, 6 key objectives progress.
afternoon, Chair Simidian and Supervisor Lee. Sherry Terrell, Director with our Behavioral Health Services Department. You have our written report, and we have two of our division manager directors from Behavioral Health, Mego Lien and Lon Win, here to answer any questions you may have.
Thank you very much. Let me check and see with the clerk. Do we have any speakers either here in chambers or online?
I have none in chambers and one online.
I think what I'd like to do is let the speaker online go ahead and be heard, and then see if there are questions from the committee members. Go to it.
Our speaker online is Ben Z. You'll have 2 minutes to speak. The timer will start when you begin speaking.
Yes, one of the objectives that I believe is missing from this report is more of a preventative thing. I'll give you an example. Like my son, you know, he told me what he told me about being abused, and nobody helped him. And now he's reporting that he's suicidal. He's because of that. And if the county would have just done something about it beforehand, when I first reported it back in 2015, none of this would have happened. I mean,
Madam
it would have
Clerk,
been
would you
prevent-
please cut the time for just a moment? Mr. Z, I've tried to provide quite a bit of leeway about the opportunity to speak on agendized items, but this is a report about a specific set of objectives, and I really do want to ask you, sir, to make your comments specific and germane to the report and the objectives, rather than a repeated recitation of your own personal circumstances. So with that in mind, I'll ask the clerk to continue your time.
Yes, I am speaking to this report. I mean, it's about suicide prevention, right? And I'm just trying to give an example, and I want to move past the example that I gave you in my case. And I want to say that there's a taboo about talking about these things. Like, you're not supposed to talk about issues of suicide that arise from family court. If it happens in the context of family court, or somebody with power is involved, then you can't talk about it. And what happens is you have an increased rate of suicide. I mean, like it's not just happening to me. There are other parents whose children are having to live with this abuse day in and day out because the county is gaslighting them. And if we could put this in this report, put more of an emphasis in one of the objectives of prevention, and removing these taboos that you can't talk about these things, not in public meetings or anywhere else, it would greatly benefit the community. Thank you.
That concludes public comment.
Thank you, Madam Clerk. Supervisor Lee, my recollection is that you had leaned in on this set of issues previously, so let me defer to you.
Thank you, Chair. First, I want to thank the Prevention Services Division for the report back in January, and then following up with the next step for each of these 6 key objectives. The work of Suicide Prevention Oversight Committee has also been instrumental in this process, so I'd like to make sure it's clear that we really appreciate all of your hard work and the efforts to get our arms around these suicide prevention issues. Under Objective 1, what are the potential replacements for the Cognito and crisis response trainings? Because it sounds like we're going, quote, incognito by getting rid of that at the end of this fiscal year.
Yes, Cognito will be going away at the end of this fiscal year. We've pulled together an ad hoc committee to review available suicide prevention and mental health trainings for schools. And that committee recommended that we pilot with the school districts next year the Be Sensitive, Be Brave online trainings, which was actually developed here in our county with our SPOC partners, with our Suicide Prevention Oversight Committee partners. And then for possible replacements for the crisis response trainings and consultations, we're considering a number of options of existing partners from the state, from school administrators we've partnered with in the past, and then some staff from contracted organizations.
Thank you. Now, on the objective 2, the report also mentions that the interventions workshop report for increased suicides among Latinx and Asian populations will become available in early fiscal year 2025. Can the Prevention Service Division also please share this with the HXC when this report becomes available then?
Yes.
Okay, great. Thank you. That's all I have. Sure. Thanks.
Thank you. Can I get a motion to receive the report?
Yes, so moved.
Motion by Lee, second by Semidian. Want to make sure we didn't cut you off and that there wasn't anything else you wanted to offer?
No.
Please call the roll.
Vice Chairperson Lee?
Aye.
Chairperson Semidian?
Aye.
Thank you.
Motion carries unanimously. Thank you all very much, and thank you for the work. Item number 7 was placed on our consent calendar, so that takes us to item number 8 for the Al-Cove informational report.
Good afternoon, Chair Semidian, Supervisor Lee. We have Zelia Friacosta and Jennifer Pham presenting on the school, my apologies, on the Al-Cove update.
Thank you. That's
It's turning it off instead of turning it on.
There you go.
Good afternoon, supervisors. My name is Zelia Faria-Costa. I'm the director of the Children, Youth, and Family System of Care with the Behavioral Health Services Department. And with me, I have Jennifer Pham, who will be doing a short presentation on our Al-Cove informational report. And then we'll be happy to take any questions you may have.
Good afternoon, supervisors. I'm Jennifer Pham. I'm one of the division directors for our Children, Youth, and Family System of Care, and I oversee our outpatient specialty services, and Al-Cove is one of my programs. So next slide, please. Just to give you an update on our programming at Al-Cove, what you see here is some updated photos of some of the decor updates that we've had. Just a quick, briefly, we added some greenery to the site, and as well as some artwork to the site. Next slide, please. And so this is our agenda for today. I'll be covering a little bit about the updates for our youth advisory group, the recruitment that's coming forward with our 7th cohort, some marketing and communication program highlights, some of our outreach and engagement events, as well as the workshops and presentations we've done, and some utilization information. And to start off with, just to give you an update on our YAG, which is our youth advisory group. The YAG this past year has been really supportive of infrastructure at the center. They've participated in hiring process. They've collaborated with the Al-Cove team on hosting the Al-Cove open house that was done a few months ago. They partnered with Al-Cove staff to offer new workshops like ones around neurodiversity, and they collaborated with the Youth Liberation Movement to create a Youth Bill of Rights that will be used throughout all of Santa Clara County to ensure that all youth receive services they need. And so for our 2024-25 YAG recruitment, we are currently in process of that. That is our 7th cohort. Applications are underway right now with the end date of May to receive those applications. We've been outreaching to schools, community colleges, high schools, various community partners to get applications for our 7th cohort. And we're hoping that we'll be able to identify a 7th cohort in the new fiscal year. In terms of marketing and communications, just one of our highlights for this one is that we were able to work with our associate communications officer to create some bus ads that ran through Santa Clara County. Hopefully you saw some of our bus ads floating around on our VTA. So that's been a huge success. Some of the youth that have come into the center have shared that they've seen our bus ads, so that's wonderful. And then we're also working on social media ads as well. And we also continue to send monthly updates to our distribution list around events that are happening in the center, which I will go to the next slide to add to. So as you can see here, some of the events and workshops that we've had. The open house was a good attendance with 26 attendees in person and 11 virtually. We've hosted topics around life school, career, mindfulness and practice. We've done a fall festival with activities, social events, Hooked on Crochet workshop, which has been actually a pretty well-attended event, and then Mental Health and Me Art Night. Presentations and advocacies that the youth and our peers have participated in is Elevating Youth Voice, a youth panel discussion, partnering with the City of Palo Alto, and attending the Al-Cove conference. And we also have another Al-Cove conference coming up actually today, a virtual conference that our folks are attending to as well. And next slide, please. And what we can see here is some of the efforts that we've put through, some of the new efforts, as I mentioned, the bus advertisements, social media advertising, partnering with some of our individual and group private practices, youth services, and psychiatry to build that partnership for ongoing services, neighboring cities, working with them. And one of the ones that I wanted to highlight is creating YouTube content. So we have been partnering with our YAG as well as our peers to really think about material that we can put onto YouTube to talk about mental health and substance use and be more of the preventative and reduce that stigma in terms of receiving services. In the schools, we've been teaming with our wellness coordinators and having regular monthly meetings with school wellness around building in curriculum and how Al-Cove can support some of that. We participated in the Eastside Union High School College Night, and then in the community, we partnered and had tabling events at various community events throughout the year. Next slide, please. And this is our utilization for the center. The top slide, or the top graph that you see is since inception, and we have had, of the 303 youth surveys that we received, and these are youth who have come to our center, utilized services, and provided a satisfaction survey or completed a satisfaction survey. 95% of those youth have identified that they would recommend Al-Cove services to a friend. 690 community events were, had during the since inception, and 96% of youth were satisfied with the services that they received at Al-Cove. The bottom two graphs you can see is cumulative services distribution and then the current distribution of services. The current is from March 2023 to February 2024. You can see roughly that the same levels of services were provided, majority going to behavioral health services, and then secondary is our peer support services. And the other ones that have ebbed and flowed in terms of utilization is our supportive and education employment services and our psychiatry services. And then the last slide is just our next steps and some of our efforts moving forward, continuing our outreach and marketing through social media ads, funding opportunities and sustainability. We mentioned this in the report. We're working with the MHS OAC to really think about sustainability of the programming in the center and the sustaining the financial sustainability of the center. Developing youth leaders, YAG facilitated workshops, working with the YAG more to really develop that peer-led and driven curriculums, and then building those community partnerships, partnering with our schools and communities, neighboring cities to really identify what the needs are. And that's the end of the report. Any questions?
Let me check and see, do we have speakers on this item?
There are no requests.
All right, thank you. I want to ask a little bit about San Jose in a minute, just to foreshadow that. But before I do that, with respect to the Palo Alto site, what's your thinking about the level of utilization?
Utilization ebbs and flows, and it really is dependent on what's going on in the community. Right now, we're seeing a high walk-in rate because there's a lot of stuff going on at school, the end of the year, graduation, college applications are getting received. So there's more youth walking in just to check in and participating in some of the activities that we have as well.
Let me try it a different way. If there was an additional outreach effort that generated additional demands for service or requests for service, could the facility accommodate them? Could the staff accommodate them?
Yes, we are fully equipped to be able to serve, and we have adequate staffing to support the needs.
Well, first I should have said thank you for all the work that's gone into making this possible. And I'm remembering, as I suspect staff is, how long it took us to get the facility up and running, which was a story in and of itself. I'm anxious that the utilization, the number of teens and young adults who are actually using the services, accessing the services, is as great as it can be given the level of need out there. And I know there are other programs and services, but I wanted to, my office and I will think through and perhaps be in touch with you about expanded opportunities for outreach. One of the challenges we have with any geographic location is that it's more convenient for folks who are close and it's less convenient for folks who are farther away. A challenge, and Supervisor Lee, you may have had some experience with this as well, that I think is sometimes difficult to communicate is that in our smaller cities and towns, people can sometimes limit themselves unnecessarily to the particular city or town in which they live or work or go to school, and let those artificial city limit lines get in the way of accessing services. What's your take on the extent to, I mean, one of the reasons I thought the location was a good one is that it's relatively easily accessed by folks on 101, folks on Oregon Expressway, Page Mill Road, Middlefield Road, the location of the venue. Are we getting engagement and participation from neighboring communities, bordering communities, or is it still, frankly, pretty Palo Alto-centric?
The majority of the services that are provided are for those within the Palo Alto community. We do see youth that come in from various areas. Some of them actually as far as like Livermore. We've had some come and visit the center just because they heard about the center. But the majority of the youth are in the community.
All right, thank you.
May I add something
Please.
here? I just wanted to add that because we've also had other opportunities to expand these types of services in other areas, for example, our Downtown Youth Wellness Center, which provides similar services to the Al-Cove Palo Alto, youth would also will also be utilizing those services. But as Jennifer is mentioning, we do see youth from all over the county that utilize Al-Cove, and they do many presentations across our system of care to our community providers and other folks. That Al-Cove is available to any youth in any community within our county. And also the expansion of wellness centers in general through our Wellness Center Grant Program, I think we might see an additional impact as more wellness centers become available throughout the county, particularly at high schools.
Let me pivot to the San Jose location, which of course opened, faced some challenges. Some of them were facilities challenges, some of them were location, neighborhood challenges. And we have, as I understand it now, something that is similar to, but not technically the same as an Al-Cove operating in San Jose. Is that a fair characterization?
Yes, that is correct. So the Downtown Youth Wellness Center provides all of the services that Al-Cove provides with the exception of the medical component. So we have peer services, the employment and educational supports, behavioral health services, and then the variety of workshops and just community engagement, et cetera. So the one piece that they don't have is the medical component.
And the medical component is in close proximity, though.
It is across the driveway from the wellness center.
And I don't want to oversimplify, so if you want to help clarify, correct, elaborate, please do. I think the Al-Cove model places some emphasis on all of those services being under the same roof in order to destigmatize accessing any one set of services. Is that a fair summary?
Yes, to destigmatize and engage youth, but we do see, as you saw on the slide that Jennifer was referring to, that the medical component, it is the least utilized component of the Al-Cove.
Got it. And with the name we're using now is the Wellness Center, did I get that right?
Mm-hmm.
Is it your expectation that in the next 6 months to 2 years, there will be a transition back to a pure Al-Cove, or that the Wellness Center is likely to stay the model in use for this particular population in this particular location?
I think for the location that we're at, we have been very successful with the services that are being provided, so I don't see that we would transition back for that particular location, to an Al-Cove model. Part of the reason was because part of the reason why it's not an Al-Cove is because we couldn't do the medical component at that location, and we were utilizing the downtown clinic right next door for the medical component. But because it was not under the same roof, if you will, it cannot be called an Al-Cove. It's not the fidelity to the model, so.
Understood. So are we in the process of seeking out another Al-Cove venue, or are we accepting that this is a variation on the model that we think is serviceable and provides benefits to the community and to young people, and that we should maintain and sustain it without looking for a new Al-Cove venue?
So I'll start by answering the question, and perhaps Sherry can also lean in. We had identified a location on the east side San Jose on North White Road for an Al-Cove center. We were in negotiations with the landlord for that location to be able to build an Al-Cove center there, but it didn't move forward because the landlord was not amenable to the terms and conditions that we had. We also had submitted 2 different applications to the state for grant funding for an Al-Cove center. As you know, the budget for Al-Cove is a high budget for the services that are being provided, and we were not awarded those services. So at this point, we are really prioritizing the wellness centers. We just released, 2 or 3 weeks ago, the list of schools that were awarded through our wellness center grant program. So I think it's about 8 schools in the catchment area of that location that had been identified for Al-Cove were awarded funds for a wellness center. 4 of those schools are in the same zip code as the identified location for Al-Cove San Jose, 2 of which are high schools that will be receiving funding for a new wellness center. There are several other schools that are within that same location. They're like about 3 miles from the actual address of the identified Al-Cove space. And then the downtown wellness center is within 5.5 miles of that address. So we feel like we have a robust array of different services in that area that are similar, not the same, but similar to the Al-Cove services. So we'll be providing accessibility to mental health and substance use services. We'll be providing screening, assessment, counseling, et cetera, in that area for children and young people.
Thank you. One more variation on the theme here, and that is any information you can share about the development of Al-Cove centers in San Mateo County? And if not. I thought since
I don't know all the specifics. Jennifer might be able to speak to that, but I believe they've had their soft opening.
Yeah, so the San Mateo Al-Cove has had their soft launch or soft opening about a month ago or a little bit more than that. So the Al-Cove Center in San Mateo does not have the medical component to it. That's why it is a soft opening for them.
And when you say San Mateo, are we talking about, they have the San Mateo problem that we have with Santa Clara problem. Are we talking about the city of San Mateo as the location for their Al-Cove?
That I would have to get back to you on. I do not know the physical address of it, but
Okay.
they are calling it the San Mateo Al-Cove.
Okay, thank you. All right, thank you very much. All of that was helpful, and as I say, I'm particularly interested in thinking through a bit more and then following up on potential for outreach to ensure community awareness and access is real. Supervisor Lee?
Yeah, thank you, Supervisor Median, for many of the questions I was going to ask regarding the San Jose Al-Cove. I mean, it sounded initially disappointing to hear that those leads did not work out, but it sounded like there might be a workaround with the Downtown Youth Wellness Center and having the medical services across the driveway to provide similar type of service. So my better question is going back to, we saw the beautiful pictures of the Al-Cove in Palo Alto. I haven't seen any pictures of Downtown Youth Wellness Center. Is there pictures of those, or is this something you could provide to us in the next meeting so we can actually do some comparison in terms of space, in terms of the amenities being provided outside the medical side? Do we have something relatively similar?
Actually, I was just looking through those pictures today.
Great.
It is equally as beautiful and inviting and welcoming, and I invite you to come and tour the place.
Great.
It's really nice.
Good. Okay, I look forward to that that tour. I also like to see there are. I think it was earlier. I was mentioned there were like 20 or so these wellness centers that we're expecting to put throughout the district. So, Dr. Terrell, is it possible for us to get some locations or even a map where these locations are, so can try and see how good the coverage is of these centers?
Yeah, so we can provide that information.
We can definitely provide. It's also on our website, so there'll be up to 40 wellness centers that will be either receiving funding for either new wellness centers or enhancing an existing wellness center. So we expect that up to 29 new wellness centers will be developed. And for this area that we're speaking of in East San Jose, it'll be a robust number of wellness centers there as well.
Sure.
So we're very confident. I want to say one more thing because I think it's really important to highlight this. There are two types of things that we look at when we're looking at the wellness centers: the school-based wellness centers and then the community-based wellness centers. And I think it's important in our county that we have both, because some students feel very comfortable in receiving services on school sites, and we're trying to do more of that because that's where they are. But we also know that there's a number of youth that are very vocal about being able to receive services outside of their campuses. And so that's why we feel it's important to also have the Downtown Youth Wellness Center.
Right, and these type of wellness centers, will they be in Palo Alto as well?
I don't have that number of like the distribution, but I don't believe that Palo Alto were selected through the equity criteria that was used to select the wellness centers. But we definitely have all the locations for you.
Okay, so part of the reason I asked that question, I know I have my former mayor from Palo Alto sitting next to me right here, who still lives in the city. As we have also learned, various schools, especially gun high schools, have absolutely the highest number of suicide rates among many of the schools in our region. It's extremely high-performing schools. Kids do very, very well academically, but by the same token, the pressure and the mental stresses is phenomenal when you have that many suicides per year, and you can see it year after year from the same school. I'm just trying to figure out if there's any way that our Al-Cove or our wellness center, any type of services we could potentially provide to help these type of situations, since we could actually identify the school that seems to have these numbers so awkwardly off from other schools comparatively speaking.
I wish I had my SLS expert here today, but she's not here today. So I'm gonna say that some of the schools in the North County have their own wellness centers. So they may not have been selected through our wellness center grant funding, but they have their own, and they're doing their own work with their own staff as well.
Yeah, if there's any way you could maybe
Yes,
get the
I will
information
provide
to
the
us in the next
information.
HXC meeting,
Yes.
that'll be very helpful. Again, I'm just trying to provide as many resources available to the children, to the kids here,
Absolutely.
basically, especially when we see the problem. I mean, last item, we talked about the African-American issues. Now here, we suddenly see this specific high-performing kids that's having issues. So I really want to make sure that we are serving that vulnerable community as well in that sense. as our county is certainly moving to a very tough budget process in the next few weeks, I was made aware of an opportunity to increase money. So, of course, my ears perk up at the Al-Cove Palo Alto through the Family PACT funding, which provides reimbursement for family planning services for young people. That this is actually a type of state money from California, from Sacramento, that could provide reimbursement for services already being performed at our Al-Cove. So I would like to ask the administration to explore a family PACT application and get back to us maybe in August. Would that be doable? Great. And that's all the questions I have, Chair. Thank you very much.
Thank you.
Actually, sorry, just to go back to your question in terms of the location of the San Mateo, it is in the city of San Mateo.
Thank you very much. And I am aware that the folks in San Mateo County are looking at other possible venues in San Mateo County, and anything we can do to be helpful, I think, would be appreciated. So just a heads up on that. All right. Then the motion is simply to receive the report.
So moved.
And I will second. In the absence of any public comment, we'll ask for a roll call vote.
Vice Chairperson Lee?
Aye.
Chairperson Smithian?
Aye.
Thank you.
Motion carries unanimously. That takes us to item number 9, and this is the report. Ms. Terrell, thank you on Proposition 1.
Correct. Thank you, Chair Simidian and Supervisor Lee. We have a brief presentation, and then we'll be open to questions. We have Darren Tan, Caitlin Liu, and Jan Morrell here to present on Proposition 1.
Thank you all, and forgive me, I forgot to say thank you to the Al-Cove team for their report as well. Much appreciated. Welcome. Who'd like to tell us what?
Good afternoon, Chairperson Simidian and Vice Chair Lee. Darren Tan, Deputy Director, Behavioral Health Services. We have a brief presentation which will provide an overview of the passage of Proposition 1 and what we know so far. And the panel here and I will be happy to answer questions.
Thank you.
Okay, next slide, please, Kathy. So Proposition 1, on the high-level summary, I wanted to provide a couple of key highlights to share. Proposition 1 changes the MHSA funding to now BHSA, which is the Behavioral Health Services Act, which will expand eligible services to include substance use disorder treatment services. Some other high-level changes include a 30% set aside to fund housing with housing first requirements, and also a new structure for planning, data gathering, reporting, and accountability across all county behavioral health funding streams. Next slide. So as we know, Proposition 1 passed in the March primary election, which was just a few weeks away, and so there's very not too much information has been shared yet, as I believe the state is still working through some of the details. And so what we like to do is just provide a high-level kind of understanding of what we know of fiscal impacts of BHSA for now. So if you can go to the next slide. I wanted to note to the committee here that BHSA isn't set to commence until July 1st, 2026, which means that next year we will proceed with our current MHSA plan, and no new changes are expected or required through the BHSA Act for fiscal year 2025. One thing I wanted to just remind the committee here is that, as we all know, MHSA funds are historically volatile, so projections now can change, by the next quarter, just depending on what the tax revenue comes in looks like. And with that being said, for fiscal year 2025, the department has been working on reviewing its allocation of MHSA funds and noted it was not commensurate with our current expenditures. However, there is a plan in place where we were able to identify additional revenue streams, alternative funding sources to offset some of the expenditures of fiscal year 2025. And we feel that services that were affected as part of the plan for next year will not be impacted. With that said, for 2026, there is an additional 5% additional allocation to the state. Previously in MHSA, it was a 5% allocation that the state deducted from the budget, and now that's going to be increased by double to 10%. And that's going to be going on an ongoing basis starting in 2026. Lastly, the one thing that is going to be a change from previous MHSA reporting is the new BHSA budget process requires county behavioral health departments to include all funding sources in the engagement and planning process for BHSA. Additional details are anticipated from the state, and that will provide more direction on this process. Again, this is what we know so far, and we continue to receive updates from the state. As we do, we will be sure to update the board. Next slide. And so as far as next steps, again, this is very high level. Our department intends to begin planning for implementation of BHSA from the statewide level. We're going to participate in statewide work groups. It's still being determined through the state that will provide input on the development of state metrics and annual reporting templates for the newly required integrated plan, incorporating all behavioral health funding sources. Secondly, ongoing assessment of revenue and expense estimates, updating county fiscal impact figures as appropriate, evaluating the startup costs potentially associated with the implementation of BHSA, determining whether there is an initial ramp up and any new ongoing costs based on any enhanced administrative requirements that the state will be asking departments to report, and also for our community engagement process as well. And then lastly, as referenced for community planning, we're continuing to reevaluate the department's stakeholder engagement process as it aligns with the new BHSA requirements. Convening internal work groups, mirroring the statewide work groups that have been preliminarily identified, and gather and represent other departments and stakeholders in the county towards the states in the statewide level. And lastly, hosting local stakeholder engagement meetings in the coming months to provide information and updating the implementation plan of the BHSA. And that concludes our presentation, and we're happy to answer any questions.
Supervisor Lee, let me check first with the clerk, see if we have any speakers on this item.
There are no requests.
All right. Supervisor Lee.
First of all, thank you so much for the report. Proposition 1 is now passed, and by the slimmest margin, to say the least. So there are some follow-up questions we want to figure out, because obviously we've been reading a lot of marketing material about this. Now the rubber hits the road. It's going to impact us quite a bit. So I would like to ask, by starting the requesting the administration in order to learn more about the potential impact to our county's behavioral health services starting in 2026. If BHSA eliminates the county-based prevention funding priority, would this 4% population-based prevention allocation be enough to cover the current prevention work in our county, or even expanding this work?
Good afternoon. Yes, while the 4% state-led prevention will be available as well, but then our prevention services, whatever we decide to do in the behavioral health department, will be incorporated with the current BHSA categories that is available.
Right. And then there's the other thing. The state's supposed to take over this work in workforce education and training, right, as part of their so-called 10% allocation. Does that mean that this is all done by the state now, or counties still have a role in this area of work on the education training?
It would be the same thing as the prevention services, where if the state-led already has that portion, but in addition, if the county were to provide those additional services, it will just be part of the 3 categories within the current BHSA.
Okay. And the new allocation would put down 23% for housing, 34% for FSP, and 43% for BHSS. How would this decrease allocation to housing to 23% as proposed affect the current and future housing projects in our county?
As of right now, in order to reduce the impact of the current BHSA passing, the county behavioral health did an evaluation, and it was best to keep it as the 23% based off of the state allowable adjustment for the first year, and we'll continuously evaluate and add additional housing in order to get to the 30 as appropriate.
Great. And that's all I have for now. Thank you, Chair.
Thank you. I have no additional questions at this time. I do just want to look to county staff and confirm from the earlier slide and from the materials we have, effective date is 2026.
That is correct.
I'll be gone and I wish you well. Let me put it to you that way. That being said, I think it's important that our county plan for that future. And my observation about most organizations, human nature perhaps in general, leaning into the microphone on this one, is that, and this organization in particular, is that the urgent can sometimes crowd out the important. And I think that planning is going to be important. So I just hope that for the remainder of 24 and into 25, we find the time and the bandwidth somehow while people are dealing with the urgencies of the moment to plan for that future, because I think it's going to be a significantly different world. Maybe not, but I think so.
Your point is well taken, Supervisor. And so even prior to knowing whether the proposition would pass, we were already very engaged in trying to plan for and anticipate what some of the potential changes could be to, given if Prop 1 passes. And so that community planning process, engagement with all sectors will continue throughout fiscal year 24, throughout fiscal year 25 in anticipation of fiscal year 26. But again, really appreciate your comment. It's well taken. Thank you.
Thank you. Motion to receive the report?
So moved.
Second by Simidian. Call the roll.
Vice Chairperson Lee.
Aye.
Chairperson Simidian.
Aye. Thank you very much. Motion carries unanimously. Thank you to you all. And good luck. That takes us to item number 10, which is the report on the West Valley Mental Health Access Expansion.
Thank you, Chair Simidian. With us today is, of course, Michelle Delicaya, from our Office of Integration. Sherry Terrell and I are here to answer any questions from the report. As you note, we are currently working with Laura from Valley Health Plan for a contract with specific clinics. We can take any questions if you have any at this time.
Thank you. I had asked for this timeline. I appreciate it. Let me ask the question this way. Well, first let me say thank you for the response to the referral on expanding mental health access to the West Valley. That being said, in the fall of 2024, this year, looking at the timeline, briefly, crisply if you can, what will be available in the West Valley in the fall of 2024 that wasn't available in the West Valley in the fall of 2022, 2 years ago? As a result of this effort, we are now fill in the blank. Who'd like to take a shot at that?
I'm happy to. I have notes here. So VHP will be contracted with Pacific Clinics for in-person and telehealth services, including individual and group therapy, psychiatric consultation, medication management, health navigation and system coordination, crisis de-escalation, and continuity of care, including coordinated access for intensive services for all lines of business with Valley Health Plan through Pacific Clinics. And that's the anticipated contract of services that would be provided.
And help me understand, for folks who are not part of VHP, what additional services, if any, will be available in the West Valley?
Pacific Clinics will be expanding their location in the Los Gatos site. They're not only serving persons, they have additional lines of business, and we can follow up with Pacific Clinics on additional lines of business or services that they might provide in that community. But before this collaboration and work together, Pacific Clinics didn't provide adult services in the West Valley location. And so they've opted to expand based on this agreement and collaboration with Valley Health Plan.
So the cooperation and collaboration, and please correct me if I have this wrong, the cooperation and collaboration with Valley Health Plan is facilitates, accommodates not only service to the VHP members, but by virtue of having that relationship, it puts Pacific Clinics in a position to provide services as well beyond which was previously provided to folks who are not members of the VHP network. Yes? No? Feel free to correct me right out here in public. I'm trying to understand it.
Unfortunately, we don't have Pacific Clinics here to talk about their other network and where they might have coverage. But I know in previous discussions, they also partner and contract with the other Medi-Cal managed care plans and behavioral health for additional services. Having that Los Gatos location allows them to have a footprint in the West Valley, which was limited to, or not limited, but only served children and families prior to this engagement with our teams.
All right, I'm going to ask for, go ahead, Mr. Lawrence, please.
Supervisor, I would add, when we speak of Valley Health Plan contracting for all lines of business, that includes the PCAP program. So those that don't qualify for any other type of coverage would qualify potentially for the PCAP program. So those would be those that are not covered by the programs. So this really is an added benefit to the community in terms of the availability of these services.
All right, I'm going to call an audible here, so bear with me. Looking at my team, can someone pull up the date of the referral for this that came out of our office? And if we'll just ask your forbearance, everyone, because what I'd like to do, Mr. Lorenz and Ms. Terrell, is ask for an off-agenda report back, and I'm going to look at the calendar here real quick and see if we can find a date that works for all parties. The 15th of May is a Wednesday, and I am, sure enough, I didn't pick that 2022 date by random. I believe my staff is telling me that we did the referral October 15th of, 18th, excuse me, of 2022. Okay. I wonder if we could get a report back off agenda, Mr. Lorenz, and if the timing is problematic, please just say so, by May 15th about essentially what's available, what will be available in the West Valley by the fall of this year, which will be 2 years from the time that I brought the referral. And just trying to get a sense tangibly for, all members of the community, what have we been able to do in that time frame? All right. We will look for that, and I'll look to my team to make sure that we look for it on a timely basis and sort of take that opportunity to take stock and see where we are, what progress we have been able to make, and what progress remains yet to be made, so that if I have both the need, I also have the opportunity to one more thing you with what about this or what about that, which would be two more things, I guess. All right? Thank you. I think that does it for me today. I'm looking forward to the report back and kind of an opportunity to get a bigger picture of what's what now that I have a sense of the timeline. And the timeline is helpful because it does suggest to me that fall of this year would be a good time to take a look and sort of assess. But I want to do that looking forward so we're ahead of the curve. All right. We have no speakers on this item.
That's correct.
Motion from Supervisor Lee to receive the report.
So moved.
And I will second. We'll call the roll.
Vice Chairperson Lee?
Aye.
Chairperson Simonian?
Aye. Motion carries unanimously. Thank you very much. Thank you. That takes us to item number 11. And we're going to talk about the possibility of a health clinic at West Valley, serving the West Valley, rather, on the Anza College campus. Supervisor Lee, I'm going to tell you I had the opportunity to sit in on and participate a little bit in the campus conversation about all this just recently. But let me see who's going to present. Mr. Lorenz, are you going to present?
I'll start out. I'm not sure if Jeff Draper from Fleet and Facilities is joining me.
Mr.
I
Draper?
would first start off by thanking the supervisor for allowing us to join the chancellor in his town hall meeting last week, where we had the opportunity to present to a number of different stakeholders that had interest in this project. I think this is probably the first of a number of different type of community events where they're going to get input about the project. So I think we're off and running in terms of making sure that the community is aware of the importance of this clinic to the community. At the last Board of Supervisors meeting, or the time before, we had the opportunity to present to the full board of the estimated cost of the project, ranging from 47 to 54 million. And a new letter of intent was issued on March 20th of 2024, this past March, to lease the property situated on the Anza campus to start the process in the negotiation in the development of the site. So with that being said, I'm going to turn it over to Jeff Draper if he has any further comments.
Mr. Draper is in the webinar. I'm not seeing an open microphone, however.
Okay, with that, Supervisor, I'll turn it back over to you for questions.
Thank you. Supervisor Lee, I think what I would tell you is after, it's been about 2 years since you and I put the referral in the hopper, I think progress has been made. Our board has indicated its commitment to the project, and certainly the board at Foothill Anza has, on 2 occasions when I have visited with them directly at open and public board meetings, has indicated not just their support, but their enthusiasm for the project. This is my characterization, and my characterization only. I think it is fair to say, based on the feedback that we've gotten prior to this recent meeting on the Anza campus, and then very directly at the campus, that we have arrived at that moment when people are suddenly engaged by and attentive to the activity that has been taking place for the last couple of years. And, you know, as is often the case with land use projects and in the planning arena, you know, in a perfect world, you'd get all that good input early on, but in the real world, it takes a while for people to decide that they're going to engage and to bring their, well, what about this and what about that questions. And there was a fair amount of that at the most recent meeting. A lot of it has to do with as I understand it, once monthly flea market and its continued viability, given the fact that there would be a medical clinic on the site where some of that activity or all of it takes place. A lot of it had to do with the potential that folks were concerned about for a project of this sort to, in some way, detract from, interfere with, compete for attention with community college building projects that were largely unrelated to this, but that might be happening in sequence or simultaneously. And there were other questions and concerns, but it was clear that there was a lot of communicating that needed to be done that had yet to be done. To everyone's credit, I think Chancellor Lee Lambert was very clear that he looked forward to having those conversations with faculty and students and staff. So I think while progress has been made, we are at the point where the various stakeholders on the campus are about to engage more fully, and I think that's the next necessary step. Now, Mr. Draper, I gather, is not able to access us or us him, but my understanding, Mr. Lorenz, is that the next step is to negotiate a land lease.
That is correct, Supervisor.
All right, well, here's, and I'll look to our Chief Operating Officer. as the officer on deck supervising all of this. I really would be disappointed if we let a year go by while folks were talking on campus and then started negotiating a land lease. I think we got a little bit of a chicken and egg challenge here, so I'm hoping that we will ask Mr. Draper and his team to move forward expeditiously on negotiating the land lease, because until we have terms and conditions on a land lease, we don't really have the ability to move forward. And frankly, we don't have the ability to assuage the concerns of folks on campus about what is or isn't being proposed. As you can, as I think we would expect, people can imagine all kinds of things that aren't in the realm of possibility if they're not given something tangible that is, here's what the proposal looks like. So I do want to ask that we hustle it up in that regard. And let me see, Ms. Olson, if you get, Hanson, excuse me, if you've got any comments or thoughts about that timeline.
No specific comments or thoughts, but certainly hear the request, and we'll be working with FAF on making sure we're moving forward with things in the right order.
All right. Supervisor Lee, thank you again for co-authoring this initial referral with me. Any comments or questions?
Just a really basic question is regarding the funding of this project. This is coming from the 10-year capital improvement program, is my understanding. And I just want to make sure that all that seems to be tracking, yes?
Supervisor Lee, my understanding that this is front and center on the capital improvement planning process. And so depending on the timing of the facility will be the time in which I believe the OBA and the county executive will make recommendations.
Okay, great. I know we've been talking about this parking spots to ab nausea, but in the meantime, right now, as far as we know, there's plenty of vacant stalls in the parking lot in the Anza. And so to us, it doesn't seem to be a big issue. Is that still hanging there, or are we still trying to resolve it?
I'll speak, Supervisor Lee. I think on the issue of the capital projects, and I don't know if Ms. Hanson's in a position to comment or not, but my impression is that while the item may remain in the list of 10 capital projects, that there's not going to be a lot of money, as in none, for design of such projects in the coming year, given our budget status.
That's correct.
And I don't mean to be flip, I think I would describe it as front and center but unfunded.
I think that's exactly right.
All right. And, you know, hard to find a silver lining, for me at least, in that description. I'm thinking the same face that you're making, Supervisor Lee. On the other hand, in the absence of a land lease and in the absence of some community consensus, campus consensus, it may be that the year is necessary. I can't get more positive than that, but that the year is necessary to sort all that out so that if and when funds are available in the subsequent fiscal year for design, which is not an inconsequential cost. I'm always, no disrespect to the architects and designers, but I'm always sort of set back in my chair by how much it costs to just design it. I think until we have the land lease squared away and the campus consensus more fully developed, it's probably premature anyway. So I can't say I'm excited by that, but resigned / accepting might be it. Further grimacing from Supervisor Lee, leaning in from Ms. Hanson. Supervisor Lee, go ahead.
Yeah, so as we know, when it comes to designing, it takes sometimes many months, if not years, to design something. And as we know about how design works, is that not all of the funding really needs to be upfront to make happen. If there's something we really want to proceed, is there any way we can break it up? Because some of the design work, like upfront work, might not cost necessarily a lot, but it's time consuming and it has to go serial, not parallel. So I'm just trying to come up with ways to see if there's a smaller dollar amount of what we know can get started so we don't really have to start from square one a year from now. I'm just trying to keep this thing moving. So I'm just going to propose that, Chair, is that a fair question to ask? If there's any way we could ask the administration to come back to see if there's any way we could break up this design planning work so that possibly a small amount could get the baby rolling, so to speak.
Let me turn to our COO, who's leaned in and put her light on.
Thank you, Supervisor. Certainly, the notion of breaking up the funding for the project into phases is the typical way that we proceed, and is what you'll see reflected for the projects that are proposed for funding in the forthcoming CIP, but very happy to have the conversation with you about how we prioritize, frankly, just the very challenging decisions the board's going to have to make about what to fund on the capital side and on our other ongoing operational side as part of the CIP process. But that question, as you posed it, will be teed up, and there'll be an opportunity for the board to weigh in specifically on that as we have the CIP discussion.
As we have the which discussion, forgive me, I just didn't hear you, presumably because you weren't speaking into the microphone the way I have been counseled I should.
The 10-year capital improvement plan CIP discussion.
Thank you. All right, thank you very much. With that somewhat unresolved set of observations, can we get a motion to receive the report?
So moved.
I'll second. Let's call the roll.
Vice Chairperson Lee.
Aye.
Chairperson Simitian.
Aye. Motion carries unanimously. Thank you very much. That takes us to what I think of as our omnibus item number 12. And the first item of business there, of course, is the report from the Chief Executive Officer of the Valley Healthcare. Mr. Lorenz, what would you like to share with us, if anything?
Thank you, Supervisor. At this time, I think I'll pass to see if you have any questions. But before I do that, I just want to comment and thank the board for hearing our concerns relative to the impact of the changes that the Regional Medical Center is proposing. And we, as directed by the board and obviously by the county executive, are looking at the impact from a health system standpoint, and further information will follow. With that being said, I'll turn it back over to you.
All right, thank you. Supervisor Lee, comments or questions?
None this time, thank you.
All right, then let's go on to 12B and see if the Public Health Officer has anything else to share at this time.
Just one brief mention that the Public Health Department is very closely monitoring the announcement about 2 weeks ago now of the first detection of Aedes aegypti mosquitoes in Santa Clara County. It's actually our second detection ever, but the first one where there have been multiple detections. And we're incredibly grateful to Vector Control and SEPA for the immense work they're doing to try to wrangle this new vector, because if we're unable to stop it in its tracks before it gets embedded in Santa Clara County, that will substantially change the risks of certain diseases here. So Public Health is working hard to amplify the messages of Vector Control to help get these mosquitoes under control, help the communities impacted in East San Jose let Vector Control folks into their areas to do mosquito control, and to report any daytime mosquito bites directly to Vector Control. That's all. I'm happy to take any questions. Thank you.
Let me just ask this follow-up question, and I'll look again to the COO when I ask it. Are the resources available to move at the speed with which you think you need to move?
In public health, with respect to our response, at this stage, yes, because we have a team that is monitoring the travel-associated mosquito-borne diseases that we handle here. Were there to be a substantial change in local vectors, we'd have to revisit that. As to Vector Control, I'll refer to Ms. Hanson.
I'm not aware of any resource-related constraint, but I'll look into that and let you know if I've identified any.
Let me share my concern, and it's clearly a layman's concern, but it's also a policymaker's concern, and it's a concern expressed by someone who served as chair of this committee through the, I'll call it 3+ years of the COVID epidemic. I think I know by this time, from the hard experience that we've all had together, that when it comes to vector control and when it comes to public health, time is of the essence. I look back at the COVID crisis and ask myself, how different would our world have been had testing been readily available and widely dispersed in the earliest days of the crisis? And I think the honest answer is we'll never know. And you know, two very different phenomena, I understand that. But I just, Ms. Hanson, not to put the weight of the world on your shoulders, but I do want to say I'm raising the concern here today because I want us to be absolutely sure we don't have an oh my God moment simply because procurement or some other part of our large bureaucracy needs to sort of move itself into position to address a need, or we haven't budgeted something and we have to wait to a board meeting or whatever. So if we need to be on it, like right now, I just want to make sure that we don't get in our own way and we're on it like right now. Okay.
Totally hear that, and I think we on the administrative side learned a huge amount about how to surmount hurdles that had existed prior to COVID that we encountered during COVID, and are in a much better position today than we were then to surmount those sorts of obstacles, both in terms of the resources that have been allocated to public health, but also our nimbleness as an organization to, in the face of that sort of threat, jump on it. That said, we need to stay on it, and I will certainly be working closely with Dr. Redman and with folks from SEPA and Vector Control, as I think we've all probably who've been spending time outside as the weather's gotten warmer noticed that this is already turning out to be quite a mosquito season. And so actually I think it will be important for us to continue to share with the public updates on what we're learning with respect to mosquito vectors given the wet weather and how much of a different season we're facing in addition to this specific threat.
Thank you. Anything else before we move on to item 12C? Any additional report from behavioral health?
Nothing to add, Supervisor. Thank you.
Thank you. 12D, Valley Health Plan.
Thank you, Chair Simidian. Only update I have is that we are now over 230,000 members, which is the highest VHP's ever had. So that those numbers are new since the report was submitted. And I'm here to answer any other questions you may have.
Thank you. Supervisor Lee, all good?
Oh, good.
Okay. 12E, Custody Health Service.
Good afternoon, Supervisors. Nothing new to add to the report. Happy to answer any questions.
Are we making progress?
We are incrementally. We are making progress.
Okay. 12F, Emergency Medical Services.
Good afternoon, Supervisor. The main update to our report is that our impact report was sent to CDPH and to the EMS Authority on Friday evening, the 19th. We are meeting with Regional Medical Center weekly and asking for all relative data pertaining to the reduction, and we'll be providing that here on a regular basis. So, and that's all the update on RMC at the moment, but I am here for any other questions on the remainder of the report.
Can you refresh my memory at least on what the timeline is now that we've sent our letter in on the 19th for a determination by California Department of Public Health?
If I may.
Please.
The CDPH, California Department of Public Health, does not actually have a defined timeline, but
I should go work for them.
But from sort of our analyses of similar responses that they've made to these types of impact reports, it appears that they generally respond within about 60 days.
Where are we then on the 180-day timeline, if I'm remembering correctly, that Regional has?
Their date that they selected was August 12th of this year.
So if the state were to act consistent with past practice, they could step up if they chose to on a first ever basis within that, before the expiration of that 180 days.
Correct.
Okay. And trying to keep my question appropriate for an open public setting, your office at the board's behest is looking at a range of options that might be available to our county if the state acts as it has with similar previous items and just says, sorry, we're not going to take any action.
Yeah, a very wide slate of options that we are exploring, yes.
All right. Just want to reiterate that as one board member, I certainly encourage that. And I think as much as I am hopeful, I'm not terribly optimistic about the state, and therefore think we need to look at a full suite of options. Okay. Supervisor Lee, anything on regional? I do have some more questions for Ms. Lowther, who knows I'm going to come, I think, with some questions about our ambulance contract and about our on-time rates.
Well, certainly you've asked a lot of questions on that previously, so none today. Thank you.
All right. Then, Ms. Lowther, let me start with our on-time rates. I know folks are doing a lot to try and get us to a better place. I'm not as confident that we're able to have an impact on the challenge. What's your take on this?
It is steadily making progress. Staffing is getting to a better place. The earn while you learn is increasing staffing at a steady pace. And the open positions are decreasing. However, positions are, or medics are leaving at almost a similar rate of onboarding. As you notice, the compliance for average increased during the month of February. March improves slightly, and then it goes back down. So overall, we're still struggling. The problems with the new computer-aided dispatch, we continue to work on those with TSS and with county communications. So it is just level. Response times have.
How long have, Ms. Hanson, has TSS been working on this issue with our EMS team?
I may need a little bit of help from Jackie on this.
September 12th.
September 12th. She's telling me.
7 months?
Yes, sir.
I raised concerns some months ago about operations at TSS. It was scheduled for a board meeting. It was late in the day, so it was continued at my request. And then more recently, I think we put it on consent, which I agreed to. But I mean, this is, am I missing something? Is this not sort of bread and butter work for TSS?
Yes, the implementation of new systems like this is certainly core to TSS's mission. I would say, and Ms. Lowther can augment this, in that 7-month period, significant progress has been made through the work that TSS is doing. So we are not at all where we were right at the implementation of CAD. Many of the really significant core issues have been resolved and require really significant coordination and complex coordination between various entities in the county and outside the county, as well as interface of technologies that not only have we struggled to make interoperable, but as with a lot of other systems available only in the government space, the technology quality is not what most of us expect from products that are also available in the public market. That said, I think it has been a very challenging process, to say the least, and although we've made good progress, we need to make more progress and make it faster.
And I concur that it has been an extremely deep dive into a very complex system that was not originally designated for an emergency medical system. And so it has been very intricate. So it was not sort of a very simplistic system to begin with. And so they have taken a painstaking approach to getting through this. So I do think we are making good progress, though.
What will it take to actually solve the problem rather than simply make progress? Anybody?
Jackie, you might be more aware of what are the very latest problems. I know that some of the technology interface has required a pivot to use of different technology that's interoperable with our CAD by some of the external folks that we work with. So I know that some of those adjustments and transitions are underway. And some of it, I think, falls in the category of issues that one would expect to be worked out in the period of months following a new technology implementation. But in terms of the very latest details, I don't have those at my fingertips, and I'm not sure if Jackie does either, but we'd be happy to give you a much more clear and specific answer to that question.
I think we can give you a update on that perhaps at the next meeting. We just did sort of a summary of the last few months earlier this week, so involving the actual vendor. So if we can do that, I don't have that with me today, but I think we can certainly report back on that.
Ms. Lowther, I appreciate that, but I'm sort of at the point where I think our organization should be done with report backs. I think we're at the point where this problem should be fixed. And I think the board and the public have shown more patience, frankly, than could reasonably be expected given the impact. I mean, simply put, and please correct me again if I'm wrong, we are not meeting our own expectations in terms of on-time arrival. Yes, everybody? Yeah? Ms. Lowther?
Yes, sir.
And one of the reasons is that we can't ascertain what's working and what's not, and why things are as they are, because we've got technology problems. Yes?
Yes.
And if the answer is no, you feel free to lean in and say so, please. And the reason I'm asking these hard questions is I'm very mindful of and respectful of the fact that no board member can give direction to any member of the staff, with the exception of our own offices. So if we don't have that information, and we have been trying with TSS to get that problem solved for 7 months, Ms. Hanson, as the officer on deck, sorry this falls to you, but as Chief Operating Officer, what is it going to take to get TSS to deliver on this?
Supervisor, I want to be, as you've asked, that we be very precise about what actually is the holdup, and so I don't want to give you an inaccurate answer to that question, and I'm not in a position to answer how much of the ball is currently in TSS's court versus some of the external partners. I will get back to you with that specific answer.
Who are
and
the
I apologize,
external?
I don't have it
I'm
today.
sorry for the interruption. Who are the external partners? Just
The vendor who
from whom we've purchased our CAD system. And then in some instances, if the CAD system couldn't be interoperable with some of the external partners we work with, including AMR, the system they use for their dispatch, then needing them to also partner with the vendor and with TSS to make adjustments on their side. And I know that there has been really focused work as between county comm staff, EMS staff, the vendor, TSS staff, and AMR staff, and really significant progress made, including on the specific issue about how we have optimal visibility and needed visibility into response time. But in terms of what are the current final legs of the marathon of getting the CAD system fully implemented and meeting expectations, and in whose court that ball is on those remaining legs of that marathon, to mix metaphors, I'll have to get back to you.
I'm going to have to give some thought to what next steps look like from my standpoint, because I don't think we can let another month go by and end up in the same place. And you know, on management and operations issues like this, there are a limited suite of options for elected officials as board members to pursue. But you know, I would say we've tried patience, we've tried exhortation. Certainly, many of you at this dais know when it was the City of San Jose's fire department that couldn't meet their deadlines, I was absolutely determined that they get to a better place. And to their eventual credit, they eventually got to a better place. And I'm sitting here thinking, you know, this really does need to be kind of a whole of county enterprise. And when someone tells me we've got tech problems and 7 months later the organization hasn't been able to wrestle those tech problems to the ground, I don't find that an acceptable answer. Now, I don't know what the solution to that is in terms of whether I literally need to come to the board with a referral to contract out for those services. You know, I'm frankly going to be interested in looking carefully at the TSS budget, and that's going to be a catch-22 for me, because I don't really want to reward this level of behavior or performance. On the other hand, I don't want to cut off my own nose in spite of my face, as my mother used to discourage me by saying, well, we'll cut their budget, because that's not going to get it done either. So I'm going to ask everybody in this chamber who's part of our health and hospital system in any way, shape, or form to communicate with me in my office what they think the, quote, solution is, because 7 months in, that's not an answer I could give. Supervisor Lee and my colleagues tease me when I talk about sidewalk office hours, but if I were standing at sidewalk office hours and somebody came up to me and said, folks aren't getting there on time, and I had to say, yeah, that's right. And I said, well, you know, and they said, what are you doing about it? And I told them of all of our good works. But I said that, you know, one of the things we're trying to do is get a better handle on it with our technology, and 7 months later, we're still working on it. I don't think that would be very well received, nor do I think it should be. So can't do any more today. Understand the limitations of the committee. Looking at Mr. Press, who's going to tell me that we don't have the authority to make decisions here at the committee level with 2 members of our 5-member board.
That's correct.
But I just, it's time, past time. Anybody else on this part of the topic? All right, then let's move on to G, report relating to federal and state health policy and budget landscape. Mr. Margolin.
Now it's on.
Ms. Carta, I didn't mean to preclude you from leaning in. My face is over this way. My eyes are over this way.
Mr. Margolin. David Campos is in Sacramento today and asked me to cover that for him.
Thank you for being here. Mr. Margolin.
Thank you very much. Thank you. You have in your file a report on the MCO tax issue, and I'm going to limit myself today to a few additional comments on the MCO tax question to kind of put it in context and maybe supplement the report in a few respects. As the report indicates, the MCO tax remains a very important source of new funding for the Santa Clara system. It's especially critical as the larger statewide public hospital system faces a looming $3 to $4 billion shortfall that may arrive as early as 2027. There are several funding streams in the MCO tax program that Santa Clara has the potential to draw down funds from. The $150 million that's dedicated for public hospitals is the one we've talked the most about, but there are others, and I want to talk about them in a minute. But on the 150, as we know, the governor put out in January a methodology for drawing the dollars down that doesn't work for us and has the potential to not allow us to fully realize the new funding. The California Association of Public Hospitals, working with Santa Clara County, has strenuously objected to that methodology. The governor's office has said, or the agency has said, on behalf of the governor, that they understand our concerns, and we expect that they will adjust that methodology in the May revise. We have to wait to see whether that adjustment actually allows us to draw down the full amount promised, but that will be learned when the May revise comes out. And in fact, the May revise will set the stage for whatever advocacy we need to do on the MCO issue, in that there are several other funding streams that are going to be, that are in the MCO program that are not really fully defined yet. We don't understand how we're going to be accessing the emergency department funding that's available, several $100 million. There's money for hospital outpatient procedures and services, not clear yet how we're going to be able to access that. There's behavioral health money that hasn't been defined yet, and we hope that at least some clarity will be in the May revise on some of these funding streams. And to the extent that it doesn't meet our needs, there'll be advocacy to be pursued in May and June. There's also the potential, as your report suggested, and this could be another major problem for us, that with the state's massive budget deficit, that some of this funding could be pulled back or deferred. We hope not. We have no indication yet that that is going to happen, but logic tells us that it's a possibility given the size of the state's budget deficit. And if that were to happen, we'd have to respond to that as well. The last issue I wanted to highlight involving the MCO tax is that while there is an allocation that was agreed to by the legislature and the governor for all these different funding streams for different kinds of services, behavioral health, emergency departments, specialty care of one sort or another, there are a group of stakeholders that are concerned that they were not included in the distribution. And they went to the Senate Budget Subcommittee last week for a hearing that Senator Menjivar chaired. And she had a panel that she constructed that included home health care providers, adult day service providers, California Chiropractic Association, and others. And they essentially outlined their own proposals for redistributing a portion of the money. Now, Senator Menjivar, the subcommittee chair, expressed sympathy for a redistribution. It's not at all clear that either the Senate or the Assembly leadership or anyone else in the legislature is committed to that. But I wanted to flag that as one of the other issues that, as the May revise unfolds, that we'll have to contend with. It's possible the governor himself will make changes. It's also possible that members of the legislature will push for some adjustments. There's actually one other factor just to sort of highlight for people, and that is, and this really involves the out years, the future years of the MCO tax. There is a budget, there's an initiative directed at the MCO tax and ensuring that its distribution approach is memorialized through the initiative process and therefore cannot be easily changed. It's in circulation now, and it's sponsored by the same people who put together the original proposal for the MCO tax, California Hospital Association, California Medical Association, Planned Parenthood, and many others. And it's just something, it's slightly different, but not in consequential respects, but slightly different from the governor's plan. The governor has negotiated with the initiative circulators, and whatever the differences are, I think they're not viewed as significantly, at least at this point in time. Governor could change his mind on that depending upon what his May revise tells us he wants to do, but it's just important to know there's an initiative out there as well that should be on the November ballot. And I'm happy to respond to any questions you might have.
Supervisor Lee. I think I'm okay today, Mr. Morgan.
Okay.
Thanks. We've got a lot of related information earlier today at the Federal Affairs Advocacy Task Force, so thank you for that as well.
Certainly.
All right. Any last items here before we move to adjourn? Then without objection and hearing none, I say thank you all. We are adjourned.